Hi, everybody. So me and Marissa are going to be talking about the nutritional assessment of chronic lung patients and indirect calorimetry. So we all know what COPD is, but we are going to have a slightly different focus today. Dietary awareness and interventions are major when it comes to disease management. Many of these patients have limited mobility, which ultimately leads to muscle loss. And many times, because of their chronic cough and dyspnea, oral intake becomes the last priority on their list because it just becomes too difficult for them. So they need nutritional supplements to make up for what is lost. So nutrition is very important to monitor in any diseases. Chronic lung patients have a hard time breathing. So imagine you just got done with an intense workout and you're out of breath. You are breathing heavy. So try to imagine yourself eating while you're trying to catch your breath. For me, I imagine that being really hard to do. Eating while I'm trying to catch my breath is not ideal, and I would just wait a while to eat something. This is what some chronic lung patients always feel like. Because of how hard and uncomfortable it is for them to eat, they tend to eat less and become malnourished. This can reduce respiratory muscle strength and lung parenchyma. Because chronic lung patients have to work so much harder to breathe, they use more energy, which can require up to 10 times the amount of calories that a person without COPD. Their body is working so hard to try and get oxygen. So because they are working so hard and burning so many calories, they may experience unintentional weight loss. This weight loss can make them weak and tired. Their bodies being weak and tired can also put them at increased risk for infections. Being overweight can increase their work of breathing even more than they already have because of all the extra weight on their heart and respiratory muscles. This is where a balanced diet can help decrease that weight while still eating the right foods to keep up with their energy need demand. Overweight and underweight patients should be closely monitoring their weight by weighing themselves once or twice a week. Significant weight gain or loss. If you have significant weight gain or loss, your doctor might want to change your diet. COPD patients are already carbon dioxide retainers, so they usually have higher than normal CO2. Certain foods are better for them to stay away from because they can increase their carbon dioxide levels even more. Overeating and bloating for anyone is uncomfortable. This can cause COPD patients' work of breathing to increase even more, which will only have them burn more calories and make them use more energy than they really need to. So foods that chronic lung patients should be eating more of are complex carbs like whole grain bread, pasta, fresh fruit. This gives them the energy, more energy, and keeps their weight up. They should be eating 20 to 30 grams of fiber each day. Examples, again, whole grain bread, pasta, nuts, seeds, beans, fruits, and vegetables. Protein should be with every meal, like milk, eggs, cheese, meat, dried beans, peas. They should be having the mono and poly unsaturated fats, so ones that don't contain cholesterol, like canola oil and corn oils, and they should be drinking tons of water. Foods that should be limited or not eaten at all are simple carbohydrates like sugar, candy, cake, soft drinks with sugar in them. Trans fats and saturated fats, so butter, lard, fat, skim from meat, vegetable oils, fried foods, cookies, crackers, all the good stuff. Sodium. For sodium, they should talk to their doctor about what works for them, because for that, everybody's a little bit different. So next, we're going to talk about indirect calorimetry. So the gold standard to determine, it's the gold standard to determine the resting energy requirement. The RER is energy that the body uses in a 24-hour period with no activity, and that RER maintains involuntary functions, respirations, cardiac output. Indirect calorimetry measures oxygen consumption and carbon dioxide production. It's non-invasive and helps clinicians customize the nutrition plan for their metabolic needs. And it's repeated every 2 to 3 days in patients with rapid changes to their clinical status. So why would we do indirect calorimetry? We would need to ensure we are meeting the patient's metabolic needs, that they are not being overfed or underfed because they have that significant weight gain or loss. We need to support them in every way possible and hopefully get them in a better state. And when would we not do this? If they have a tracheostomy, if their PEEP is greater than 10 or FiO2 is over 80%, if they have thoracic drains or presence of other gases like helium.
So as you can see here, it can be done with patients that are being mechanically ventilated. So the flow meter is connected within the patient's circuit, and it gathers the data, and the monitor will display the results, and a report will be created. It can also be done with spontaneously breathing patients. So it's done with a hood or a fitted full face mask to collect the inspired and expired gases. So the steps to collect the data and calculate are a bit extensive, so hang in with me, but we'll break it up, okay? So for step 1, we're going to measure the VO2 and the VCO2 with calorimetry. So the VO2 is the oxygen used, and the VCO2 is the amount of CO2 produced. And I'll go into the calculation in more detail in the next slide, but for now, we're going to continue on to step 2. So this is when we calculate the RER, the resting energy requirement. So this tells us how much energy the body uses during no activity to maintain involuntary functions, as Chloe went over. So in step 3, we're going to use a chart to get the caloric equivalent based on the RER that we calculated in step 2. And the caloric equivalent is the amount of calories burned for every liter of oxygen consumed. And in the last step, we're going to calculate the caloric expenditure. So this means that we'll know how many calories the patient is burning every minute. Okay, so now this is where I'm going to break it up step by step. So as I mentioned for step 1, we calculate the VO2, which is the amount of oxygen consumed. So we do this by subtracting the oxygen inspired and the amount expired. For example, we're going to use the value of 2.07 liters per minute of oxygen used. And for the VCO2, we subtract the CO2 expired minus the CO2 inspired, and we will get 1.87 liters per minute of CO2 produced, is what we're going to use for this example. And in step 2, we're going to calculate the RER, and we do that by dividing the VCO2, which again was 1.87, and we're going to divide that with the VO2, which was 2.07, and we're going to round that to 2 decimal places, and we'll have an RER of 0.90. So I know all those sound like numbers, but this is where we kind of tie it into what it really means. So now that we have our RER, we're going to use this chart. So we're going to find our RER that we calculated, which was 0.90. And if you see, our caloric equivalent is measured in calories per liter of VO2. So we're going to have 4.92 calories per liter of VO2. So what this means is that this patient is burning 4.92 calories for every liter of oxygen consumed. And in the last step is when we calculate the caloric expenditure. And this is measured in calories per minute. So we're going to multiply the caloric equivalent, 4.92, times the VO2 that we determined earlier in step 1, which was 2.07. And we have a total of 10.2. So this patient is burning 10.2 calories per minute. And this is how we use indirect calorimetry to estimate the energy expenditure. And there are a few factors, of course, that can affect our ratings. And just to list off a few, if the patient is hyperventilating, if they have hyperthermia, metabolic acidosis, inflammation, if they're being overfed, septic, if they're in a coma, general anesthesia, heavy sedation, hypothermia. So all of these things that can affect breathing can affect our numbers that we get in our measurements of indirect calorimetry. So why use indirect calorimetry? Because overall, this prevents the patient from being underfed and overfed, right? So it's customizing the treatment for the patient for exactly what they need. So inappropriate feedings has been associated with an increased risk of infection, length of hospital stays, frequent readmissions, mortality, and discharges to nursing facilities rather than to go home. So overall, we need to keep the big picture in mind of the patient. And by doing indirect calorimetry, we're customizing the care as much as possible. And that's all we have. Thank you so much.